I'll try to be as crisp as possible and give you a gist of what exactly is the current status of systemic therapy in recurrent and metastatic head and neck cancer. So we'll proceed. So these are my subtopics. I'll briefly discuss on all these subheadings. Firstly, I'll discuss about the systemic chemotherapy. Then we go to a couple of slides on targeted therapies and oral TKIs. Then we switch to immunotherapy, which will be a very important topic, and it is going to, it has already changed the practice worldwide, and it's going to change the practice in our country too, with the use of, with the more availability of biosimilar immunotherapy drugs, and a couple of slides on what we have from India regarding the role of systemic therapy in metastatic head and neck cancer. So, so firstly, I'll discuss what is the role of systemic therapy in first line, single agent versus doublet, and then we will discuss few slides on the doublet combinations. So at the outset, I'd like to mention that there are factors which are associated with relatively poor prognosis in head and neck cancers, in metastatic head and neck cancers, and they are usually weight loss with a poor performance status, prior radiation therapy, sometimes prior concomitant chemoradiation therapy, because patients who are already exposed to cisplatin and radiation therapy, and if they progress within a very short interval, these are the patients who actually tend to do quite bad, whatever systemic therapy we offer them. Next is active smoking. Definitely, as we all know, that active smoking hampers the hampers the beneficial effects of chemotherapy as well as radiotherapy. So that is a poor prognostic marker, and significant comorbidity, because whenever the patient has a large chunk of uncontrolled comorbidities, we tend to reduce the doses of systemic therapy, or we tend to omit systemic therapy altogether. That definitely confers a poor prognosis. So when we are planning treatment for these patients, we need to keep these things in mind, so that we can make a educated decision on what to be done for these patients. So this was one randomized trial which basically looked at the comparison of cisplatin plus 5-FU and carboplatin versus and carboplatin plus 5-FU versus methotrexate. So basically, this is a 3-arm study, as you can see here, the 3 arms. One was the cisplatin, one was the MTX single agent, which was the standard of care at that point of time. This was in way back in 1990s. So at that time, we did not have much options of systemic chemotherapy. So methotrexate was one of the standard options. Now, what these authors wanted to do, they wanted to look at the role of combination chemotherapy as well as the role of platinums in systemic treatment. So they had 3 arms: cisplatin 5-FU, carboplatin 5-FU, and methotrexate. The primary endpoint was response rate. It was not survival. So there were 270 patients. All of them were randomized into 1:1:1 fashion. This was published in JCO in 1992. So these were the response rates. So with cisplatin 5-FU, the response rate was 32%. With carbo 5-FU, it was 21%. And with methotrexate, it was just 10%. And if you look at the significance of response rates, there was significant improvement of response compared to the doublet versus the singlet. So if they compared methotrexate with carboplatin 5-FU, that was a borderline significance. But when they compared methotrexate with cisplatin 5-FU, the p-value was much more significant. So this trial was the seminal study which established the role of combination chemotherapy of cisplatin plus 5-FU as the standard treatment of systemic therapy. Now, this was the conclusion that cis-5-FU was a better combination as far as response rate is concerned, because one important factor that we need to address in head and neck cancers is they tend to recur locally, and they are many times surgically non-salvageable, or they are non-salvageable with radiotherapy also. So since these patients are very symptomatic, a good response rate tends to improve the quality of life of these patients, because these patients usually do not have longer survival. They tend to live for say on an average 8 months, 1 year, 1.5 years max to max. So improving their quality of life with a better response rate is one of the decent ways to go about. So this trial concluded that cis-5FU was a better combination compared to methotrexate. They also looked at the survival. As you can see, almost all the three arms had a very similar survival, and there was no statistical difference between these survival. Toxicity definitely was more in the doublet arm, and since we are giving 5FU along with cisplatin, there was a lot of thrombocytopenia, a lot of neutropenia, and also significant chunk of GI upset. Now, so based on the previous trial and a couple of other studies also, it was established that probably cisplatin 5FU is one of the standard regimens. So that regimen was there for a long time. Again, next in 2005, this article came up, which is from the intergroup, the ECOG group, the intergroup trial of the ECOG group. So this actually looked at the role of paclitaxel plus platinum combination, that is cisplatin, versus the standard of care, which was 5-FU cisplatin. So since paclitaxel plus cisplatin is a regimen which is more easier to deliver, and it was being practiced in many centers, this trial actually looked at the efficacy of this study. So as you can see here, the overall survival of eligible patients. So 1 year survival rates was 41% in the cisplatin plus 5-FU versus 32% in the paclitaxel plus cisplatin, but it was statistically not significantly different. So this trial concluded that the median survival of the CF group, that is the cisplatin 5-FU group, was 8.7 versus 8.1 month in the platinum taxane group. And the response rate was very similar, 26 versus 27%. GI and hematotoxicity, which was a major concern for cisplatin's 5-FU, was less in the paclitaxel plus cisplatin arm. So this is a typo. This is basically cisplatin plus paclitaxel arm, and sorry, this is rightly written here. GI and hematotoxicity was more common in the 5-FU and less in the taxane and platinum. So this basically established the role of combination of paclitaxel plus cisplatin as a standard, which has similar outcome compared to cisplatin 5-FU with a similar response rate and a lesser degree of GI and hematological toxicity. So after this, there became two standards of care. So one school of thought used cisplatin 5-FU, and the other school of thought used paclitaxel plus cisplatin. So the only advantage that this combination had is cisplatin 5-FU was a 4-day infusion. We did not have to go for a 4-day infusion, and chemo was completed just in one single daycare visit. Now, there are trials which looked at the substitution of paclitaxel with docetaxel. So we do not have a phase 3 proper non-inferiority study, but there are a couple of phase 2 studies which looked at the combination of docetaxel plus cisplatin. The key points from these doci plus cis trials were, firstly, they were all phase 2, mostly single arm. The response rates varied from 30 to 50%. And unfortunately, we do not have a phase 3 data, which shows that docetaxel plus cisplatin is a non-inferior regimen compared to either paclitaxel cisplatin or cisplatin plus 5. Now, we tend to face a lot of situation, very common situation, where we need to replace cisplatin with carboplatin. Either the patient has a renal dysfunction, or the patient has underlying auditory dysfunction or neuropathy, or sometimes you feel that the patient is not in a good performance status where you would be comfortable giving that amount of hydration. Either the patient has an underlying cardiac issue, borderline cardiac dysfunction, or the patient has a poor PS where a higher amount of cisplatin toxicity would actually complicate the situation. So in these situations, we tend to replace cisplatin with carboplatin. Now, if you ask me whether there is any head-to-head data, there is in localized disease there is, but unfortunately in metastatic disease there is no head-to-head data of cisplatin versus carboplatin. But many people use carboplatin because of the ease of administration. They have a more manageable side effects. And phase 2 studies have actually shown that they have equivalent responses as depicted in most of the phase 3 studies of cisplatin. So this is more or less a reasonably okay combination, most importantly when we are dealing with a palliative situation. Now, people also wanted to look at other platinum combinations. Like, for example, there was one study published in 2012. This was again a combination of pemetrexed with cisplatin versus cisplatin monotherapy, because why cisplatin monotherapy was taken as the standard, because there were a large chunk of trials which compared doublet versus singlet cisplatin, which did not show any overall survival benefit. So if you ask me that whether I am justified to take cisplatin as the monotherapy, cisplatin monotherapy as a standard arm, yes. If you look at overall survival, definitely we are justified. So probably that with that background, this study took cisplatin as the standard arm, and they compared it with a combination of pemetrexed plus cisplatin. So this was a proper randomized double-blind placebo-controlled trial, and it showed that the median OS was 7.3 versus 6.3 months. The hazard ratio was 0.87, and it was not statistically significant. So the primary endpoint of this study was to look at improved overall survival. Unfortunately, this combination did not improve the overall survival compared to cisplatin alone. And the progression-free survival was also similar in both the treatment arms. So outcome-wise, there was no difference in the combination arm. But they also looked at a pre-planned subgroup analysis, which came out interesting, that patients who had an oropharyngeal site as a primary, or patients who had a very good performance status, probably in these two subsets, PEM plus cisplatin actually did better and resulted in better overall survival compared to cisplatin alone. But these are all subset analysis, and the conclusions from subset analysis should be taken with a pinch of salt. As I told you in the if you look at all the patients, there was no difference in the overall survival. Hazard ratio was crossing the line. Oropharyngeal patients, there's a significant separation of the curves, and the hazard ratio was 0.59, which was statistically significant. Now, one may ask that whether adding another agent helps. Now, we all know that the standard of care till now has been a doublet, either cis-5FU or taxane plus cisplatin. But people also have looked at the combination of 3 drug regimens, taxane, cisplatin, 5FU. So most of these trials are phase 2 data. They lead to higher response rate. The response rate difference is to the tune of almost 10%. But that higher response rate comes at the cost of higher toxicity, higher degrees of febrile neutropenia, and there is no evidence, none of these trials, which has compared a 3-drug versus a 2-drug and has said that the 3-drug has actually improved the overall survival. So if you ask me, when do I want to give a patient a 3-drug regimen? Maybe somebody who is having a recurrence which is extremely painful, but the patient is having a very good performance status of 0 without any comorbidities, a young male. In these situations, for the sake of a higher response rate, I might consider giving a 3-drug regimen, but largely standard teaching for metastatic head and neck cancer will be a doublet, either cisplatin 5FU or paclitaxel plus cisplatin. Now coming to targeted therapies in combination. So we have 2 trials, the Extreme trial and the Spectrum trial. Now, the Extreme is the most famous trial of targeted therapy in head and neck cancer till date. Professor Vermorken was the primary investigator of this study. So in this trial, patients who had recurrent and metastatic head and neck cancers who were ineligible for any local treatment with a good performance status was randomized into platinum plus 5FU, that is cisplatin 5FU plus cetuximab versus cisplatin plus 5FU, which was the standard chemotherapy. patients who had a stable disease to this experimental therapy was continued on cetuximab maintenance plus cisplatin plus 5-FU. But in the standard arm, cisplatin plus 5-FU was stopped after 6 to 8 cycles, or if the patient had toxicity. The primary endpoint was overall survival, and the secondary endpoints were PFS, response rates, and quality of life. So these are the treatment doses. In the standard chemotherapy arm, cisplatin was used at a dose of 100 milligram per meter square on day 1, or carboplatin. Patients who had a renal dysfunction, they were considered for carboplatin. And 5-FU was given as a continuous infusion for day 1 to day 4. Cycles were repeated every 3 weekly, up to 6 cycles. And the experimental arm had exactly the same regimen along with cetuximab, which had an initial loading dose of 400 milligram per meter square, followed by weekly doses of 250 milligram per meter square till progression. So these are the baseline characteristics. More or less, they were quite similar. There was slight male majority, probably because the disease affects males mostly. And most common site was oropharynx. Half of the population were locally advanced squamous cell carcinoma in both groups. Around 80% had prior RT, and 85% expressed EGFR, although expression of EGFR doesn't count anywhere or doesn't figure anywhere in the treatment paradigm of these set of patients. So here were the survival curves. The hazard ratio was 0.54, which is very significant. The median progression-free survival was 5.6 months in the cetuximab versus 3.3 months in the chemotherapy alone. And also there was an improvement in the overall survival by almost 3 months, with cetuximab leading to an OS of 10 months versus 7.4 months in the chemotherapy alone. Here also the hazard ratio was statistically significant. Now, if you look at the response rates, so here around 36% of the patients in the Cetux arm had a response compared to 20%, and the median duration of maintenance for cetuximab was around 6.9, so approximately 7 months. And this is the forest plot showing the subset analysis. As you can see, who had a very good performance status of more than 80 kps, patients whose chemo backbone was cisplatin, and patients who had a well-differentiated tumor. These are the subsets, or patients who had a more than 40% detectable EGFR levels. These were the subsets basically which did the best with cetuximab plus chemotherapy. Now, as I told you that after the extreme trial, the standard of care, if we keep aside finances, the standard of care was cisplatin 5-FU plus cetuximab. But we all know that cisplatin 5-FU is a cumbersome regimen to be given. So there was this TPEX trial which looked at the role of replacing 5-FU with docetaxel. So the combination became dosi plus cis plus cetuximab versus the extreme regimen. So this was the TPEX trial. The median OS was 13 months versus 14 months. They were exactly the same. There was no difference in the OS. And after this TPEX trial, it appeared to be a new option for first-line recurrent and metastatic head and neck cancer. The advantages being that dosis can be given in 1 day. You don't have to give a continuous infusion. And dosis had a significantly lower rates of toxicities compared to cisplatin 5-FU. So if you're planning for an extreme based regimen, you won't be wrong if you use 5-FU with docetaxel. Just cetuximab and panitumumab as similar drugs, but to take it forward in head and neck, probably the picture is not that perfect for panitumumab. So to look at that, the Spectrum trial was undertaken, where it was a very similar regimen, a very similar trial design compared to the extreme trial. Here also, as you can see, the standard chemotherapy arm was cisplatin 5-FU, and the experimental arm had cisplatin 5-FU plus panitumumab. Here, the primary endpoint was overall survival and a very similar secondary endpoints of PFS and response rate. But unfortunately, unlike the extreme trial, the median overall survival did not differ with the addition of panitumumab to cisplatin plus 5-FU. As you can see here, the hazard ratio 0.8 and the p-value was not significant. However, there was improvement in the progression-free survival. It improved from 4.6 months to approximately 6 months with a hazard ratio of 0.78, which is also not that much attractive as much as the extreme trial. And they also did a subset analysis, which showed that patients probably who had a P16 tumor and those who were having an oral cavity as their primary subsite. In these patients, their OS was slightly better, and it was significantly better rather with the addition of panitumumab compared to other subsets. So if you're planning to use panitumumab, maybe you should restrict the patients to only P16 positive or the oral cavity tumors. But ideally, since the trial was not designed to look at these subsets specifically, I would consider the Spectrum trial as a negative study. So if I may summarize till now, the standard of care, if you consider only chemotherapy, are two equally good regimens, paclitaxel plus cisplatin and cisplatin plus 5. Now, if we have to combine a targeted therapy along with that, we can combine cisplatin plus 5-FU with cetuximab, which has offered an overall survival of 10 months. And if we have to replace 5-FU, we can do it with docetaxel. So we can use a regimen called docetaxel plus cisplatin plus cetuximab, as I shown in the TPEX trial. So till now, I would say the standard of care, if we keep aside finances, will be either a cisplatin plus 5-FU plus cetuximab or a docetaxel plus cisplatin plus 5 cetuximab. Now coming to the role of TKI, largely TKIs have not made a significant ground in the management of head and neck cancers, although you all must agree with me that you will also find a significant chunk of prescriptions coming out from many oncologists prescribing erlotinib and gefitinib left, right, center. But honestly speaking, the data with erlotinib, gefitinib, and afatinib are really not that exciting that would translate into a significant clinical benefit. So there was a phase 2 study of erlotinib where erlotinib was given at a standard dose of 150 milligram, irrespective of the EGFR status. Disease stabilization was seen in around 40%, and the median PFS was 9 weeks, median OS was 6 months. This was not a comparative study, it was just a phase 2 single arm study. Similarly, we had a trial of gefitinib where it was a phase 3 study where gefitinib was compared with methotrexate, which was another standard of care. So this was the standard dosing of methotrexate, 40 milligram per meter square every week versus gefitinib 250 milligram every day. Here also, there was no difference between methotrexate and gefitinib. So gefitinib failed to improve the outcomes of patients when they were compared with methotrexate. Although, if we talk of now, present situation, methotrexate is definitely not the standard chemotherapy backbone. And also we had another trial of afatinib called the Lux Head and Neck 1 trial, where patients were randomized in a 2:1 fashion to methotrexate versus afatinib. There was small difference in the progression-free survival. So it was 2.6 versus 1.7 months. I would not call it as clinically significant. And if you look at the overall survival, there was no difference in the overall survival. So the summary from these TKI studies were they had a very small and modest benefit. Only the afatinib trial showed a small PFS benefit, but that is not clinically significant. And they are their role in the treatment of this subset of patients is clearly not well defined. So I would not call the use of TKIs as one of the standard treatments. Now coming to immunotherapy, because immunotherapy is coming a large way in most of the cancers. It has picked up ground in head and neck cancers also. So I'll take you through the data that we have both in the first line and in the second line regarding the role of immuno-onco drugs. So this was the Keynote 048 study. So in this trial, patients who had SCC of the oropharynx, oral cavity, hypopharynx, and larynx, which were recurrent and metastatic and incurable by local treatment with a good performance status and a tissue availability of PDL1. I'm not saying that PDL1 positivity, tissue availability of PDL1. So these patients were stratified based on their PDL1 expression, performance status, and the P16 status. So these patients were randomized in a 1:1:1 fashion to the extreme regimen, which is the standard of care, that is Cetux plus cis-5FU. There was a middle arm, which is the Pembro plus chemo arm, where combined to this, other than the cetuximab, pembrolizumab was combined with cisplatins plus 5FU.
एक मिनट
And the pembrolizumab was continued up to a
अरे
total of
क्या क्लास चालू एक
Uh,
घंटा आहे
can you
कोण
please
आंघोळ करून घे तू
can you please mute the
झाली
audio?
पण हा 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 ठीक ठीक हा हा आज
So pembrolizumab plus chemo combination given as an induction for 6 cycles, followed by pembrolizumab maintenance. And there was one arm that was pembrolizumab monotherapy, where it was given every 3 weekly for up to 35 cycles. If you look at the baseline characteristics, the TPS score more than 50%, the CPS score more than 20%, and the CPS score more than 1%, all of them were very similar in all the forearms. So there was not much of a difference in the patient profile of this trial. So just a small word about the TPS, CPS. So TPS is basically tumor proportion score, where mostly the tumor cells which expressing PDL1 are taken into account and made into a calculation. And a CPS is basically a composite score where both the tumor as well as the tumor infiltrating lymphocytes PDL1 expression is taken into account and a composite score is developed. So these are all basically various ways to interpret the immunogenicity of the tumor. So coming to the results, as you can see here, there is separation of the curves. So this is Pembro plus chemo versus the extreme regimen. Hazard ratio was 0.7, which was statistically significant. The median OS in the extreme arm was 10.7, as was in the original trial, which improved to 13 months with the combination of pembrolizumab plus chemotherapy. Now, if we look at the response rate, the overall response rate was exactly similar, 35% in the pembro arm versus 36% in the extreme arm. So this we have seen in many oncology trials, that probably pembrolizumab addition does not increase the response rate over and above chemotherapy significantly, but it tends to make the disease stable. So we might not actually derive a PFS benefit, but the patients who are on treatment are usually for a longer duration, and the patients tend to have a longer overall survival compared to the standard treatment. So that same thing is portrayed here. Despite having a similar response rate compared to the standard regimen, there was an overall survival benefit with the addition of pembrolizumab. And if you look at the adverse events, they were very similar in both the arms. The extreme arm and the pembro plus chemo both had grade 3-4 of adverse events of around 80%. And most of these adverse events were manageable. And the adverse events which were specifically more in the extreme regimen, that is cetuximab arm, were mostly hypomagnesemia, rash, and acneiform dermatitis. But if you look at the other side effects, they were more or less quite similar in both the regimens. Now, if we look at the side effects, so this is more or less a similar thing. So patients who were given the cetuximab plus chemotherapy, they had a higher grades of anemia, neutropenia, and thrombocytopenia. But patients who were given pembrolizumab, they had a higher degree of endocrine dysfunction. So we all know that autoimmune hypothyroidism is a very common feature. We tend to we have to actually monitor the TSH levels at regular intervals, and so it is almost to the tune of 18 to 20% in these patients who receive pembrolizumab. So rest of the side effects is more or less similar in both the arms. Now coming to a subset analysis of this trial. So patients who had a CPS score of more than 20, that is a significantly immunogenic tumors, in them the 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 OS of Pembro alone was significantly higher. So there was almost a 5-month benefit in the median overall survival compared to the extreme regimen. And if you look at the curve, this basically is wide separation towards the later part. So this means that this overall survival is definitely persistent. So patients who have a very high score, you might actually consider them for only pembrolizumab and spare them from the toxicities of combining pembro with chemo or the extreme regimen. They also looked at the CP score of more than 1 because it was one of the stratifying factors. Here also, the median OS was improved with Pembro alone, but the degree of improvement was lesser. So around 2 to 3 months of improvement compared to 5 months as in the CPS score of more than 20. So these two slides basically tells me that patients who are immunogenic, either more than 1 or more than 20, pembrolizumab is a good combination compared to the extreme regimen. And this is the PFS, which this type of PFS curve is very common in immuno-oncology drugs, that there is initially it appears to be worse and then finally it crosses the other curve and goes into a superior arm. So this is more or less similar in most of the immunotherapy trials. So here also the median PFS was 3.4 months versus 5 months in the Pembro versus extreme. So the PFS was actually slightly less, 3.4 compared to 5. And here also, this is in CPS 20 patients. And even if you look at the CPS more than 1, the PFS was 3.2 versus 5. So if you look at the primary, if you look at the PFS, probably pembrolizumab is inferior. But if you look at the OS, pembrolizumab is superior. The reason for this confusion, I told you previously, that immunotherapy actually stabilizes the disease in a significant chunk of patients. So you do not have very good response rates or PDs, but they tend to stabilize the disease for a longer duration compared to the chemotherapy. And also, all these trials have looked at the response rate based on the RECIST criteria. But the world is slowly moving towards the direction of assessing the response of immunotherapy drugs with the help of immune RECIST criteria, which is a more specific criteria as a response rate in case of immunotherapy drugs. So probably once we have immune to the picture, we will probably get rid of this discrepancy in the PFS and the OS of immunodrugs. So this is more or less the similar thing. Now coming to the second line after progression. So you are given the first line treatment either with the extreme regimen or with pembrolizumab in patients who are showing a good CPS score. Now in the second line, I would clearly confess that there are no clear winners as far as chemotherapy is concerned. So most of the chemotherapy regimens in the second line have been either taxanes if they have not been used in the first line. If you have used cisplatin's 5-FU in the first line, you can go for either a paclitaxel or a docetaxel. Methotrexate is a good combination. It is one of the most common second line regimens used in our country. And also if the patient has not received cetuximab in the first line, you can go for single agent cetuximab in the second line, because there is data that single agent cetuximab sometimes leads to a response rate of around 12 to 15%. But whatever regimen you give, the response rate are quite modest. Rarely they cross more than 20%. And there is recent data that immunotherapy probably works well compared to the standard of care in the second line. So as you can see here, both pembrolizumab and nivolumab have been tested in the second line setting. So here all patients who recurred within 3 to 6 months of multimodality treatment with platinum or a progressive disease after platinum-based treatment. So patients who had a very short disease-free interval, so basically very high-risk group patients, They were randomized into standard of care. Standard of care means methotrexate or docetaxel or cetuximab versus pembrolizumab at the standard doses of 200 milligram every 3 weeks. The primary endpoint was overall survival. So here are the results. The primary endpoint significantly improved. P-value was 0.01 with a hazard ratio of 0.8. And if you see numerically, the median OS was 8.4 months versus 7 months in the standard of care with a less amount of side effects. If you look at the grade 3 adverse events, so it was around 13% in the pembrolizumab versus 33% in the chemotherapy arm. And the most common adverse event, as I told you previously also, was hypothyroidism. So with this study, the role of pembrolizumab in the recurrent setting was established as the standard of care. Now, they also looked at the subset analysis because they analyzed the CPA score with the outcome. So here, if you see that patients who had a CPA score of more than 1 and patients who had a PD-L1 TPS score of more than 50, so both basically means a highly immunogenic tumors, they had a very nice separation of the curves compared to those who had a lesser CPS score or lesser TPS score. So this again proves that probably these are the patients whom you should ideally be targeting with Pembro rather than those who have a low CPS score. But again, I would reiterate that this trial was not designed for only high CPS or high TPS score patients. It was designed for all comers, but this is just a subset analysis. Just like this previous one, nivolumab was also looked at in the second line setting. So patients who had fast relapses less than 6 months, they were included. The arms were very similar. The standard arm of either methotrexate or docetaxel or cetuximab, and the experimental arm of nivolumab at a dose of 3 milligram per kg body weight every 2 weeks. Here also the primary endpoint was overall survival. So as you can see, very similar to the previous one, 7.5 months of OS versus 5.1 in the standard arm. A hazard ratio was also very similar to the previous one, and the grade 3-4 events was also very similar to pembrolizumab, and there is a clear separation of the curves towards the tail. So this trial again proved that nivolumab, just like pembrolizumab, is also effective in the patients who have progressed after initial platinum therapy. Now, if you look at the subset analysis, probably patients who had a PS of more than equal to 1, patients who did not have a cetuximab used prior to the immunotherapy, and patients in whom the standard arm was methotrexate. These three are the subsets which actually fared the most or fared the best compared to the other ones. So if I may summarize for you the role of immunotherapy in head and neck cancers, it is definitely active. Both nivolumab and pembrolizumab are approved in resistant tumors, means patients you have treated in the first line with platinum, they have progressed. In these situations, you can use either nivolumab or a pembrolizumab with a very similar efficacy and a very similar side effect profile. Pembrolizumab has established its role in the first line. We do not have any exciting data of nivolumab in the first line, but if you are using immunotherapy in the first line, it is better to go for the CPS score. Very few labs actually offer the CPS and the TPS score, but if you have the access to these labs, and if the patient shows a more than 1% or a more than 20% of CPS score, use of pembrolizumab will significantly improve the overall survival. And there is obviously a clear set of toxicities which are very unique to immunotherapies, which we need to keep in mind and monitor the patients for these specific side effects, like, for example, hypothyroidism, hypopituitarism, autoimmune colitis, and autoimmune hepatitis. And sometimes autoimmune skin changes like rash and TEN. So these are the common things that we tend to look for. Now, one or two slides on what Indian studies we have in the metastatic setting. This was one publication by Dr. Vijay Patil, who is a very nice colleague of ours, the role of oral metronomic. So here patients were given erlotinib plus celecoxib plus methotrexate weekly This was a phase 1-2 study, and it showed a PFS of around 71%, 3-month PFS, and a 6-month OS of around 61%. And the response rate was quite good, around 42 and 43% of the patients actually had a good response rate. And this actually looked at refractory and early failure of oral cancer patients. So this kind of a response rate in the second line is something that is really exciting. And we have another study from Dr. Vijay Patil, again from the TMH group. This was a randomized trial of around 110 patients. There were 2 arms. One was the standard single agent cisplatin arm of 75 milligram per meter square. And the other was the oral metronomic combination that I just showed you, that is slight modification of that. So it contains celecoxib and weekly methotrexate. The primary endpoint was progression-free survival. As you can see here, the PFS was 100 days in the metronomic arm compared to 66 days in the cisplatin arm with a statistically significant p-value. So maybe in patients who are not affording for immunotherapies, or you do not have the access to CPS coding, this data can be extrapolated to our Indian patients, because this data has been from the Indian population. So the newer avenues that we have in head and neck cancers is, one is the role of palbociclib, because palbociclib in combination with cetuximab have been tested in patients which are HPV negative disease resistant to platinum. So why palbociclib is used? Palbociclib is basically a CDK4/6 inhibitor, which has established its role in breast cancer. Now it has been seen that inhibition of CDK4/6 with palbociclib actually upregulates the EGFR expression. So higher EGFR expression means there will be a better response rate with cetuximab. So this is basically the mechanism which has been exploited to look at this combination. So this data is coming up. We are yet to see the mature phase 3 data. We also have a Palatina study which looked at this combination of palbo plus cetuximab. Unfortunately, it was a randomized phase 2 trial, but unfortunately it did not show any benefit. And there are other trials of other immunotherapy agents like durvalumab, and also some trials on alpelisib, which is a PI3 kinase inhibitor. That those things are also coming up. But as of now, immunotherapy, both in the first line and then in the second line, has shown the maximum OS benefit. And in patients who are ineligible for them because of whatever reasons, finances or non-availability of the drug, cisplatin 5-FU stays the standard of care. And in the second line, you always have the option of using either methotrexate or taxane or a single agent cetuximab. So my take home message would be, standard first line is extreme regimen of chemo plus cetuximab. Alternatively, pembrolizumab is one of the standard, provided the CPS score is more than 1%. Docetaxel may be used with platinum as a chemo backbone. You don't always have to give 5-FU infusion. And for second line, immunotherapy is the only agent which has shown a significant OS benefit. So if possible, we can use these, either nivolumab or pembrolizumab. And the other options obviously are methotrexate, cetuximab, and taxanes. So there are a couple of interesting studies. So in the next 1 or 2 years, we'll be coming up with more precision approach towards treating head and neck cancers, and we'll wait for that. So I think with that, I will conclude. So I'll be more than happy if you have any questions.